So thank you again for this invitation. It's a fantastic meeting. Thanks to our organizing team for putting this together. Today we're going to be talking about ACL tears in adolescents. So why we shouldn't treat them like little adults. So ACL tears in teenagers is a true epidemic. 65% of all the acute traumatic knees that we serve in the emergency room, it's going to be an ACL tear. And this has been increasing 2.3% every year. If we see it as hours of exposure, it's 1 over 10,000 in adolescent athletes. And what is the highest risk profile? The teenage girl multisport. It reaches 10% risk of having an ACL tear during high school. This is tremendous. So we are not the only ones that are aware of this. It's all over the press because this is a devastating injury. In terms of costs, of times, of the risk of evolving to osteoarthritis, the higher risk of re-injury that's been reported in this population, and in spite of a high return to sports, low patient-reported outcomes. So probably this is the most important thing that we have to highlight here in teenagers, that prevention is better than any cure. Since 70% of these injuries are non-contact, so this means they are preventable. We have to look for programs that reduce risk and target it into these high-risk populations. So do training programs reduce the modifiable risk factors? So there are multiple biomechanics studies that have shown significant improvement in neuromuscular training, as you can see in this picture. And there are many programs. They are all based on plyometrics, strength training, balance, agility, and stretching. And they all show an overall protecting effect against ACL tears. So probably the most popular one is the FIFA 11 Plus, or the FIFA 11 Plus Kids, that is for kids until 13 years old. So it's a 20-minute exercise with no implements needed, 3 levels of different progression and difficulty, and multiple studies backing up its favorable effect over protecting ACL tears. Also, this is the PEP, that's from the Santa Monica group, another set of exercises similar to the FIFA 11. And it has this amazing randomized controlled trial that shows in over 1,000 athletes a 70% risk reduction. There were 3.3 times more ACL tears in the non-trained group. So probably in this topic is the highest quality of evidence we have around knee surgery. There are 8 meta-analyses pulling more than 10,000 cases that say that there is significant evidence favoring the use of these programs. Kate Webster published this meta-analysis of meta-analysis showing that there's conclusive evidence that there's a significant risk reduction and a cost effectiveness in implementing these programs, with a global risk reduction of 50%, and especially in female athletes of 67%. And it's relevant at what age do we implement them, because the risk reduction is much higher if it's under 18 years old, as we can see in this study. So doing some prevention in this population is a must-do. But what happens when we already have an ACL tear in teenagers? So is there any role for conservative treatment? There are emblematic studies, meta-analysis, and systematic reviews that have shown subsequent meniscal and chondral injuries because of persistent knee instability and a significant need of activity modification in this population. This recent multi-center study is very interesting and shows that every week of delay means a 2% risk in meniscal tears. This means that 10-week delay is a 20% risk of a secondary meniscal injury. So we only reserve conservative treatment for very specific patients. This is partial tears or very low demand patients or willing to quit any pivoting activities. And it's very important to keep close follow-up of these patients. So for me, ACL reconstruction surgery has 2 main pillars, and this is estimate growth remaining, to know when to use techniques that avoid growth arrests, and to reduce failure rate in this high-risk population. So we will see these 2 pillars in more detail. So estimating growth remaining is something like predicting the weather. So it's really difficult, and we know that there are some tools that are not reliable, as the Tanner or the chronological age. You see that all these patients have the same chronological age, and they look significantly different. So the best tool that we have available is the bone age. So we can use the Saunders scale, or I prefer this HSS shorthand that is really easy for any knee surgeon to take a look at a hand X-ray and see what's the bone age. Or there are also some new tools that have showed us how to easily assess growth remaining in knee MRIs. So what we need to do is to see our teenager and see if it's a closing physis patient that will benefit from an adult-like reconstruction, or if it's a patient that has a significant growth remaining, meaning that we have to do fissure sparing techniques, because we don't want to mess with the physis in the growth spurt, its higher velocity period. So there are many graphs like this that try to summarize what are the different techniques available. So teenagers fall into this category. It's females with between 11 and 14 years of bone age, and males between 13 and 16 of bone age. That, as you can see, we have at least 3 viable and valid options regarding the technique for this zone. So we're going to see this in more detail. We can go all epiphyseal, that is one option, partial transphyseal or hybrid techniques, and the transphyseal respecting techniques. So we published in this article the review of the literature regarding each of these and how they have been compared. And there's no significant difference regarding growth, arrest, or failure. So there's no technique that is categorically superior to the other, but we have to know the pros and cons of each. So what about all epiphyseal? It's technically demanding, especially the tibia, getting that very short tunnel with a quite important killer turn. And in spite of going under the physis, it has been reported growth arrest, specifically because of femoral overgrowth, because of stimulation of the physis. And recent meta-analyses have also shown that it has a trend to a higher re-rupture rates. And on the other hand, what about transphyseal? It's probably one that has more evidence pooled in the literature. But the concern is the non-anatomic position of the femoral tunnel and a rotational instability in these high-risk patients. Also the graft diameter, that you tend to use a smaller graft. So my preferred technique for this patient is the partial transphyseal, that you get the best of the both worlds. So you go with an anatomic position of the femur, but a central tibial tunnel, and the central portion of the growth plate in the tibia is the first part that starts closing, so it's safe regarding growth arrests. So now we're going to go to the second pillar of the treatment strategy, that is, how do we reduce the failure rate in this population, or we attempt to do it? So the first thing is the graft. We know that in this population we have to avoid allografts, 4 times more risk of rupture. Another thing is that diameter seems to matter. So the classic study is the cutoff of 8 millimeters. More recent studies in teenage population have shown that maybe 7 millimeters is a also reasonable cutoff. In my hands, I try that no graft beyond 8 millimeters goes inside the knee, unless very specific, very small patients or very narrow knots. So here you have to be familiarized with techniques of triplication, or also the quads graft is an option so that we don't struggle with the graft diameter. And we have talked a lot about the addition of LATs, so I'll get good, and the stability experience have shown us the importance of additioning this procedure to these high-risk patients, and that it statistically significant reduce the graft rupture and the persistent rotatory laxity in this population in particular. So this is also a must thing to consider. And what about return to sports? We know that patients under 25 years old that undergo an ACL reconstruction have a high rate of re-injury if they go to pivoting sports, of failure of the reconstruction, or a contralateral injury. And this is 7 times more if they go back to sports before 9 months. So specifically in this population, I try to hold them 12 months after completing a structured and optimal rehab with outcome measures, mean isokinetic testings, and also applying, when they go back to sports, prevention strategies as a secondary prevention. So we will round up this with a case. So this is a 13-year-old boy, meaning 13 years of bone age, amateur soccer player, 1 year of conservative treatment after an ACL injury, that has a knee failure in a jumping bed. This is a classic story of a teenager that it's supposed to not do sports or pivoting activities, but that's what they do while playing. So presents to the office with effusion, pain, Lachman, and a positive pivot shift. And this is what we see in the MRI, the ACL tear, probably non-acute, but a recent failure, and massive associated injuries, a root tear and a suspicion of a rump injury. We'll go now through the tips and tricks of the surgery. So this is the surgical positioning. We mark the relevant anatomic landmarks. I also try to mark the growth plates so that I avoid taking too much x-rays afterwards during surgery. So that is the distal femoral and the proximal tibial growth plates. And this will be our planned surgical approaches. So the lateral one is for the femoral retrodrilling and the LAT. And this one is for the hamstring harvest and the tibial ACL tunnel. And we also know that it might also add a root repair tunnel. So we start by harvesting the semi-T and the gracilis. It's important in these patients to avoid perichondral ring injury because we can have recurvatum deformities that haven't been reported. So fortunately, in this case, we had a 4-strand semi-T of 8 millimeters that we put in a cortical button and we soak in vancomycin. And diagnostic arthroscopy showed the absence of the ACL, the root injury that we repaired with a pull-out, and the rump injury that we also nicely closed there with all-inside device sutures. So then we mark the position of our femoral socket, the footprint there, and this is the interesting part of this technique. So we have this pediatric ACL guide that we can set in 90 degrees. We measure where we want to put our femoral footprint, and Dr. Kevin Shee did this fantastic study that they showed that there are 2 ways of going all epiphyseal in the femur. That is the direct lateral approach or the anterolateral approach. So the advantage of the second one is that you get a bigger safe zone, avoiding the popliteus and the LCL, and also a longer tunnel. And what it takes to do it, you have to check on fluoroscopy that you're under the growth plates, and we also use our demarcations on the skin. And then you have to flip your hand and the axial view like to upwards in 35 or 45 degrees. And then you have a longer trajectory and a bigger, safer area. So that is how we do it. So we have a 20 to 25 millimeters socket and a 7 millimeter cortical bone bridge, and we'd retrodrill it. For the tibia, similar. This is how we would probably traditionally go in an adult patient. And what we do in this case is that we're going to go really central and vertical. We shift our guide more toward the midline, and we get a really long tunnel very close to the tibial tuberosity. This is the exit of our tunnel, and you can see with the scope how you cross the physis. Always check impingement, as Bradford just showed, and that is the final position of our graft. We fix it in 10 to 20 degrees of flexion and external rotation, and we also fix our root pull-out with a cortical button, and that is the parallelism of all tunnels to avoid convergence. And finally, we do a modified Lemaire for the LAT with a central strip, as you see there, that we put under the LCL, and we fix proximal with an anchor. This is also something to highlight in this particular patients with open growth plates. So that is the position that we like of the anchor, the preferred position. But it's important that you check that it's not right in the growth plates. It's not because you're going to make growth arrest with an anchor, but it might pull out. So make sure if you need fluoroscopy, because the distal femoral physis is more difficult to palpate than the tibial one. So check it with x-rays that you're right underneath. And that is our final fixation. Post-op x-rays, and the 1-year follow-up that we see that the patients still have growth remaining, still open growth plates, and the femoral socket is under the physis. No growth arrest at 1-year follow-up. So what do we have to know about the ACL tears in these teenagers? They are not little adults. They are a high-risk profile patient that needs to have prevention strategies, both primary and for secondary injury, and that we need to know how to identify those patients that have significant growth remaining and that will benefit of using facial sparing techniques. Thank you.